Most common cause of congenital hypothyroidism is thyroid dysgenesis, especially ectopic thyroid gland, while most common preventable cause of mental retardation in children is congenital hypothyroidism. Furthermore, pendred syndrome is autosomal recessive disorder in which there is mutation of chloride iodide transporter protein, which is common to thyroid gland as well as cochlea. So there will be a sensory neural hearing loss. Pendred syndrome is triad of deafness, goiter and mental retardation. Welcome back to my channel. In today's video we are going to learn many one-liner and many image-based MCQ on the topic of hypothyroidism. I am Dr. Triyavirani Malde, pediatrician and consultant neonatologist. I'll be your guide for pediatric subject. If you are new to my channel, please do subscribe and give like to this video because lot is going to happen for pediatric on this channel. The first question is function of thyroid hormones. Your options are inhibit beta-myosin heavy chain, increases cholesterol, inhibit ovulation, or it increases diastolic blood pressure. The correct answer is it inhibits beta-myosin heavy chain. Thyroid hormone increases alpha myosin heavy chain activity while it suppresses the beta myosin chain activity. It all starts with the hypothalamus. Hypothalamus secrete the thyroxine releasing hormone which act on the anterior pituitary, and then it releases the thyroxine stimulating hormone which again act on the thyroid gland to produce T3 and T4. So what are the function of the thyroid hormone? The first function on the heart, that is cardiovascular system, is it increases the heart rate, increase the myocardial contractility by increasing the beta myosin heavy chain. It increase the blood pressure, especially increase the systolic blood pressure while it reduces the diastolic blood pressure. On the growth, it stimulates the bone growth and it helps in a teeth eruption. While in central nervous system, it increases the synapses, axons, it improves the transmitter action and it improves the myelination. While on the gastrointestinal system, it improves the motility as well, it increases the appetite. On the muscular system, it increases the expression of the MHC genes. On metabolism, the net effect is reduction in the cholesterol. In reproductive system, it enhances the ovulation in female and spermatogenesis in male, while on the renal system, it improves the GFR. On metabolism, it stimulates the protein synthesis, it increases the oxygen consumption, it improves the growth, it helps in carbohydrate, lipid as well as vitamin metabolism. The next question is thyroid binding proteins are increased by, your options are androgens, estrogen, asparaginase or glucocorticoid. Now, this has to be remembered that androgen, asparaginase and glucocorticoid inhibit the thyroid binding proteins while estrogen always increase the thyroid binding proteins. That's why in the pregnancy, more estrogen will improve the thyroid binding proteins and there will be more need of thyroid hormones. So correct answer is option B, estrogen, and as we have discussed, these three will inhibit the TBG. The next question is thyroid peroxidase will help in all except. Thyroid peroxidase is one enzyme which is involved in the synthesis of thyroid hormones. So the action of thyroid peroxidase is iodide trapping, iodide to iodine, binding of thyroglobulin, or it is a secretion of thyroglobulin into the colloid. Correct answer is A, iodide trapping. Thyroid peroxidase will do all rest of the function except iodide trapping. We are going to discuss this in next slide. If you remember this figure carefully, the green part is thyroid follicular epithelial cell. This is bloodstream. The iodine uptake is done by sodium iodizing porter, that is SIS. Iodide is taken inside, will make into the I2. This oxidation and organization of iodine is also performed by the peroxidase. It is converted into I2 and then when it's bind with the thyroglobulin with the help of peroxidase. So thyroglobulin with I2 will become thyroglobulin, MIT-DIT, monoiodothyroxine and diiodothyroxine. So coupling of MIT and DIT is also helped by peroxidase. The process is still complex and then there will be a formation of T4, T3 along with the thyroglobulin. Again it is transported to colloid and then it is bind into the lysosome. With the burst of lysosome there will be again release of T3 and T4 which goes back to the bloodstream. So this is whole procedure which is involved in the synthesis of the thyroid hormone. Here you can see that iodine uptake is done by the sodium iodide symporter, not peroxidase. Rest all functions are done with the peroxidase. Whatever T3 and T4 are formed that enter the cell, and this T3 again converted to T4 and then it binds to receptor. So next question is, fetal thyroxine detected at which age? Which age of gestation? 6 week, 12th week, 18th week or 24 week? The correct answer is 12 weeks. Thyroid hormone is first detected in the fetus by the age of 12 weeks of gestation, and its deficiency will definitely retard the skeletal maturation but not the linear growth. The next question is, most common cause of congenital hypothyroidism is thyroid dysgenesis, maternal antibodies, inborn error of thyroid hormone defect, or it is maternal iodine deficiency. We all discussed this question in the beginning of the video, and that is thyroid dysgenesis is most common cause of congenital hypothyroidism, 85% of the cases, and especially ectopic thyroid gland. So it is most common preventable cause of mental retardation. There is a feature of hypothyroidism at the birth. 1 in 4,000 infants are affected. Most common cause is thyroid dysgenesis, and this dysgenesis is due to aplasia, hypoplasia or ectopic thyroid gland. Disorder associated with congenital hypothyroidism is pendred syndrome. It is autosomal recessive disorder in which there is a deafness, goiter and mental retardation. As we already discussed, there is a mutation of the chloride iodide transport protein which is common to thyroid as well as cochlear. There is a sensory neural hearing loss, goiter and mental retardation. Hearing loss is present since birth, while goiter will develop after puberty. One more syndrome which is associated with hypothyroidism is Kocher-Debre-Semeghini syndrome, in which there is a neonatal hypothyroidism, but there is a diffuse myopathy that falsely appeared as a muscular pseudohypertrophy of the calf, particularly seen in a long-standing moderate to severe hypothyroidism which is untreated. The next question is, newborn presents with prolonged jaundice and umbilical hernia. The likely diagnosis is congenital hypothyroidism, Down syndrome, Turner syndrome or Noonan syndrome. Here we have to remember that prolonged jaundice could be part of Down syndrome, but there is no mention of facial dysmorphism. So among these 4 options, the correct answer is congenital hypothyroidism. The next question is, clinical feature of hypothyroidism in a newborn are all except sluggishness, large tongue, large posterior frontal and mental retardation. The correct answer is rest all will be present since the birth except mental retardation, because mental retardation will take some time for the development and it is preventable if thyroxine supplementation is started very early in the life. The next question is, all of the following are true about congenital hypothyroidism except more common in boys. Feeding difficulty is present, presence of refractory anemia and presence of umbilical hernia. Presentation of hypothyroidism could be feeding difficulty, refractory anemia as well as the umbilical hernia and newborn prolonged neonatal jaundice. However, it is not common in boys, it is more common in girls. So let's discuss the clinical feature of the hypothyroidism. They present with sluggishness, that is decreased activity, large anterior frontanel as well as the posterior frontanel, poor feeding, weight gain, the short stature, prolonged physiological jaundice, presence of constipation, hypotonia and there will be a hoarse cry. See, you can see the coarse facial feature. There is a macroglossia. Umbilical hernia is also present in this child. Mottled and cold dry skin. There is a developmental delay. Presence of pallor, myxedema as well as goiter. Goiter will be developed later, but if there is a congenital hypothyroidism along with goiter, then we need to remember one important cause, that is thyroid dysharmogenesis. Manifestation of endemic cretinism includes now two important entities, congenital hypothyroidism versus cretinism. We are going to discuss that what is it and what are the difference between these two. So manifestation of endemic cretinism include deafness and facial nerve involvement, blindness and hypothyroidism, strabismus and hypothyroidism, or it is multinodular goiter and mental retardation. The correct answer is option D. There is a presence of multinodular goiter and mental retardation. Which of the following is true regarding cretinism? A. Short limbs compared to short trunk, proportionate short stature, short limbs and long statures, long limbs compared to short trunk. The correct answer is option A. Short limbs compared to short trunk. Hypothyroidism will always retard the skeletal maturation. So, long bone length is maximally affected than the length of the trunk. So, the short stature will be disproportionate. It's not proportionate short stature. Here we find it will be disproportionate short stature. The limbs are more shortened in comparison to trunk. There will be a short limb as well as short stature, and limbs are short. So long limbs compared to short trunk, that option is out. Which of the following is not true regarding cretinism? Goiter present at birth, prolonged physiological jaundice present, common in iodine deficiency endemic area, and there will be a delayed in skeletal maturation. Correct answer is goiter present at birth. The goiter will develop after some time. All things will be present at the time of birth. So now the question arises, what is cretinism? It is untreated congenital hypothyroidism. The feature of hypothyroidism is present since birth, but if it is left untreated, it will be called cretinism. There is a severe irreparable mental retardation, puffiness of the face, large protruding tongue. There is a presence of periorbital edema. There will be a short stature which will be disproportionate. Arms will be more shortened than the trunk. Limbs will be more shorter than the trunk. There will be a protuberant abdomen as shown in this picture. There will be a presence of umbilical hernia, and there will be a delayed closure of epiphysis. So now the question arises, the blood specimen for the neonatal thyroid screening is obtained on cord blood 24 hours after birth, 48 hours after birth, or it is 72 hours after birth. Correct answer is option D, 72 hours after the birth. So how to diagnose hypothyroidism at the time of birth? There will be a presence of decreased total or free T4, and there will be an elevation of the TSH level. It should be done after 72 hours of the birth, because immediately after birth, before 72 hours, it may have a diagnosis of hypothyroidism due to surge of thyroid hormone at the time of birth due to stress of delivery. Concomitant T4 as well as TSH is recommended. If you have a reduced T4 but normal TSH, it could be a thyroid binding globulin deficiency. TSH only, if we go with only TSH approach, it may not diagnose the central hypothyroidism in which there is a deficiency of other hormones also. And if we go with only T4, it may not be able to identify compensated hypothyroidism. So concomitant T4 as well as TSH to be done. Knee X-ray of term baby is shown. What is the most probable diagnosis? Congenital syphilis, congenital hypothyroidism, neonatal grave disease, or it is a growth hormone deficiency. Here it is said that it is term baby, so it is more than 37 weeks of gestation. But there is absence of distal femoral epiphysis as well as proximal tibial epiphysis. So these two are absent. So the correct answer is congenital hypothyroidism. As shown in this figure, lower femoral epiphysis develop at the age of 36 and upper tibial by the age of 38. Absence of distal femoral epiphysis and proximal tibial epiphysis in term gestation suggestive of delayed skeletal maturation characteristic of congenital hypothyroidism. However, this X-ray tool of long bones are having a very poor sensitivity for diagnosis of congenital hypothyroidism. All of the following are investigation done for congenital hypothyroidism except A. Ultrasound of examination of thyroid gland, thyroid scan, ECG and echo, and cord blood TSH and T4 level. The correct answer is option D, cord blood TSH and T4. We should know that we had just now discussed that cord blood TSH and T4 may is or under diagnosis of hypothyroidism because there is a surge of thyroid hormone at the time of birth. Now we'll discuss why there is a need of ultrasonography of thyroid gland to confirm them at anatomy as well as to rule out ectopic thyroid such as lingual as well as sublingual. If thyroid is present in a normal anatomical location and there is a goiter, then it is a dyshomogenesis or transient hypothyroidism. It could be IEM of thyroid hormones. Thyroid scan is very important to see the presence of ectopic thyroid and its exit location, presence of uptake, and whether there is increased uptake or not. Echo NSAG is also important for the pericardial effusion, and there could be a low voltage QRS complex. This is very important diagram. In a thyroid scan, if we have a no uptake, then we have to do USG. If there is no presence of thyroid gland, it means it is thyroid agenesis, which is the most common cause of congenital hypothyroidism. However, in ultrasound, if we are having a presence of thyroid gland, we need to see antibodies binding to TSH receptor. If these antibodies are positive, it means it is a maternal antibodies which are blocking a TSH receptor, and that's why the baby is having hypothyroidism. If this is also negative, there is no antibody as well as there is a presence of thyroid gland, then we should suspect the defect in sodium iodide transporter, TSH receptor or thyroglobulin. Now, if thyroid scan shows the ectopic uptake, it is ectopic thyroid gland. And if in a thyroid gland there is increased uptake, it means it is a dyshomogenesis and iodine deficiency. Subsequently, we are going to discuss part 2 of hypothyroidism, that is acquired hypothyroidism, as well as the treatment of congenital as well as acquired hypothyroidism. I hope you all understood and learnt well. Your suggestions are always welcome for the improvement of my topic. Please let me know what else you want to learn from me. Till that time, take care of yourself. Study hard as well as study smart. Bye.